Thank you so much to the GOC for having me here today. I'm so excited anytime I get a chance to speak about menopause, which is my favorite thing ever. I'm happy to do so, and especially to a room of my completely esteemed colleagues. So thank you so much. So I'll let you know that I do speak for anyone and all people that ask me to speak about menopause. For free, if you pay me, it doesn't matter. I will talk your ear off about menopause. And there are a couple times in my slides where I will be speaking about off-label indications for medications. A lot of what you'll hear today, I'm sure, will be a refresher for you. You're gynecologists by training, of course, so I hope I don't have to spend a lot of time selling you on the benefits of hormone therapy, nor on the symptoms of menopause, but I will spend a bunch of time at the beginning there. And then we'll walk through the risks associated with the use of hormone therapy, in particular in a cancer patient population. And then we'll talk about what we give these patients. I wanted to start off by saying that we really need to be careful when we just use a very general term called hormones. So I'm not an oncologist, but I imagine that you don't just say the words chemotherapy and consider all things to be created equal. And I think we get wrapped up in that with menopause and saying that hormones equal this, or hormones are this risk, or hormones are good for that or bad for this. We really have to be careful when we look at studies in terms of what hormones are they talking about. Well, was it even reported? What estrogen was used? What progestogen was used? How did they give it? When did they start it? All these things are very important questions. The other piece is that a lot of studies that are done on menopausal symptoms, menopausal risks, are done in not the patient population that we're talking about today. They're done on a naturally menopausal patient population. So people that are not supposed to have hormones on board, right? So you can imagine, just physiologically, these are a very, very different group of women. The really important thing to remember is that we absolutely cannot extrapolate the risks from a premenopausal patient population and put that into a postmenopausal patient population. So I'm going to do that as I talk to you guys today, but remember that we're probably not completely accurate in doing so. So why are we talking about hormone therapy in a cancer population? Well, you know better than I do that there's a lot of cancer survivors out there that were premenopausal, reproductive age women who were having normal menstrual cycles, producing their own hormone therapy before we started with their treatments. And there's a big survivorship, endometrial cancer and cervical especially, but of course with ovarian cancer, there's a large pre-vivor group, right? The BRCA and Lynch cancer patients that we're treating prophylactically. So a big group of women here that we're speaking of. We know, of course, you better than I, that menopause is a result of most of the treatments that these patients undergo. When I'm talking about this to my patients, I break it down really basically to them. I say, we're talking about hormone therapy for two big, broad reasons. The first is symptom management. I want to make you feel better. The second, though, is because I want to prevent chronic disease. I want you to live as long as you possibly can in relationship to what your peers would have done. Why do we talk about hormones? Why is this what's important? Well, we know it's the gold standard of treatment for symptoms. It's also a good preventer of chronic disease. So what are the symptoms of menopause? Let's just review for a moment. So good. Okay. Perhaps some of us can relate. Okay. So vasomotor symptoms, or hot flashes and night sweats, these are the hallmark symptom. But it's not all that you're going to see your patients complain about. And sometimes you need to do a little bit of digging. Make sure you're asking about sleep, mood, anxiety, memory and cognition concerns. One that we don't talk about very often are joint aches and pains. So my patients will say they wake up and they feel kind of stiff and sore, just like almost like they're a bit feeling older than they should, perhaps. Sexual dysfunction and dyspareunia are very common. Urogenital concerns as well. And another one that we bring up, or we don't hear about as often, but we bring up with our patients, is palpitations. So a lot of patients will get these symptoms before a hot flash where their heart is racing like crazy, and then it's followed by a hot flash. So busy slide, but I want to prove to you that these symptoms are significant and that they are very bothersome. So we know that compared to their naturally menopausal counterparts, these patients that undergo surgery or radiation or whatever sorts of treatments, if they're rendered menopausal early, they're generally feeling the symptoms worse off than someone who would kind of naturally progress into menopause. We know that if we give them hormones, we tend to do a pretty good job of treating hot flashes, but not completely. Not everyone is treated to the point where they feel like themselves, or we're completely alleviating bothersome symptoms. So I think it's really important to keep that in mind, because I think what we imagine is, oh, we'll just give them hormone therapy and everything will be okay. And of course, I see the worst of the worst in my clinics, but I think it's important to remember that sometimes when you're counseling, you have to kind of keep that in the back of your mind, that we're going to do our best to alleviate all your symptoms, but we might not get you to the point where you were before. Sexual side effects are things that come up a lot when we look at data from patients' perspectives, and what are we missing? What are we leaving out of all of this? Risk reduction surgery specifically has a lot of data behind it, showing that there's sexual discomfort. They're twice as likely to have hypoactive sexual desire disorder as their counterparts. Some studies show that your hormone therapy that you're giving these patients is going to relieve your symptoms, but not completely and not for everyone. So it's another thing to keep in mind. And of course, I'll talk a little bit about this later, but it is something that we're sort of missing. If we move from symptoms to prevention of chronic disease, I want to point out that it's more than just bones. So I'll spend a little bit of time on all of these areas here. A lot of this data here has to do with the benign patient population, but there's big cohort studies, the Nurses' Health Study, Mayo Clinic, that have done analysis to look at patients that have had BSOs before the natural age of menopause, and if they're not treated with estrogen, then they're at higher risk of cardiovascular disease than their counterparts that are. So keep that in mind. Cardiovascular disease, cardiovascular death are increased if we're not replacing these women. The other thing is that it's interesting to think about what exactly is a hot flash, and does it mean anything else other than just a bothersome symptom? And there is a little bit of data coming out that vasomotor symptoms themselves are potentially showing that patients are at increased risk of cardiovascular disease. So perhaps there's more reasoning behind it to treat it other than just a symptom of bother. The other piece is that other metabolic indicators are also worsened if you're not treating patients with estrogens. So, I mentioned here obesity, lipids, fasting glucose. If you look at the data from the Women's Health Initiative, actually the rates of diabetes were decreased in the users of hormone therapy. So again, I'm talking about a menopausal patient population who are not cancer patients, but we do have some data that menopausal hormone therapy is good for diabetes or prevents diabetes. Bone health, I think everyone thinks is pretty much a slam dunk, right? Like whenever patients are being counseled about this, bone health is always the thing that they mention back to me. So I think it's the thing that physicians are most comfortable with. We know that osteoporosis and osteopenia rates are higher in patients that have been treated and are treatment-induced menopause. We know that fracture risks are about doubled, and we're not completely compensating, perhaps, with the hormone therapy that we're giving. We don't know exactly what dose of hormone therapy equals bone protection because the studies are so, they're non-uniform, excuse me. Cognition and mental health, I think, is really important to talk about. It's something that I think we miss, but I basically tell patients it's your brain health. There's a higher rate seen in Parkinsonism, dementia, cognitive impairment in patients that are not using hormone therapy. The interesting part that came out of some of these studies was that it didn't matter if one ovary or both ovary were removed. So there was I think we're kind of a little bit lulled into thinking that if you leave one ovary in, everything will be fine. And this is just one point where I'm pointing out that sometimes there's increased risk also associated with one ovary being removed and one being left inside. Genitourinary syndrome of menopause, I like to point out, I think you guys are well versed in this. It's the new term for vulvovaginal atrophy. But it's levels of low estrogen locally. It's something that can come up over time and progress. So if you have a patient who's well treated with systemic doses, this might be something that comes up later in life. The other thing to remember is that if she has radiation, that these symptoms can be worsened by that. The other piece to remember is that it's not all about sex. So if you have a patient who says, I'm not sexually active, don't stop there. Make sure that you're asking her, well, are you not sexually active because it hurts? Or what's going on there? Are you having any other symptoms? Or is there urogenital symptoms? Remember to ask about dryness that is not associated with sex, because some of them are more bothered than you would anticipate. And I think we miss a bunch of patients if we don't go beyond the sex questions. I think I'll just skip over this. We know that the lining of the vagina is very thinned in menopause. One of my nurse colleagues used to say that it was going from a pleated skirt in the vagina to an A-line skirt. So there's less ability for elasticity, there's less blood flow, less moisture, all these sorts of things. It's just not the same as it was. And of course, in a patient population that you see, for instance, with radiation on top of all of this, it can be worsened. So we know that local estrogen is the treatment for this, and I'll get to that towards the end. So hormone therapy is the gold standard. This is what we are using all the time in our naturally menopausal patient population, and there's very few patients that have contraindications. But there are some. So let's talk about the risks. If we're going from a benign patient population, endometrial cancer should not be increased with use of general doses of hormone therapy as long as we get it right. So as long as we're using appropriate estrogen in terms of its relationship to a progestogen, and they're not bleeding and things are investigated if they are, we shouldn't be at an increased risk of endometrial cancer. In the survivors of endometrial cancer, we have a little bit of data, and I'll get to that on the next slide. I mentioned endometrial stromal sarcomas here. Really, it's like I should have had a big red thing that said data-free zone. Like, I think this is expert opinion, and I don't think there's a lot of data to support this claim, but I think the general consensus is that people are not using hormone therapy for these patients. So we do have a meta-analysis on survivors of endometrial cancer, about 900 women who survived with case controls matched to them. A lot of them are using hormone therapy, estrogen plus or minus progestogen. So, I mean, it's interesting to see, and we can't tease out the role of progestogens here, but I'll show you the data here. So you can see that tumor stage was really early, like the vast majority of these patients in these studies were stage 1 or 2. The doses of estrogens are not uniform. Some of them have progestogens with them, some of them didn't. Some of them are on, one type of estrogen versus another. Like, how do you compare all of these together? It's difficult. But what we got from this is that, as best as we know from these prospective, retrospective studies and this one RCT, is that we think endometrial cancer can be treated with local estrogen, especially if it's, or local or systemic estrogen, especially in those that have early stage disease. If we talk about ovarian cancer, I like to start again with the general population. So what's the story? Is there an increased risk of ovarian cancer in the general patient population taking hormones? And the answer is we don't know, of course, because we don't know anything definitive about hormones, I feel. So observational data is showing small increased risks, but the relative risks are not big. They're in the realm of 1.2-ish. But then if you go to our biggest randomized control trial, which is the WHI, they don't support an increased risk of of ovarian cancer in taking hormone therapy. So maybe there's a small increased risk. It's something that I sometimes bring up with my patients, and I'll frame it in this kind of context, but it's really hard to know what the final answer will be. again, if we look at a meta-analysis for ovarian cancer survivors, it doesn't seem like the users of hormone therapy are at any increased risk of death or of disease recurrence. So observational data and 2RCTs are helping us with this, but we don't really have a lot to go on. So again, slide here showing that the tumor stage was quite varied, and again, the dose and types of hormone therapy regimens are all over the map, and sometimes we don't even know what they took. So it's hard to know, but of course with observational data, there's a lot of healthy user bias, patient preferences and physician preferences there. What about cervical cancer? I think most people think that cervical cancer is fine because the vast majority, it's not hormonally sensitive. And if it was hormonally sensitive, it doesn't really seem to make much of a difference in terms of prognosis or if there's any, from the very tiny little bit of data that we have, if you're taking hormones, it doesn't seem to alter risk of recurrence. Again, it's a place here that we're vastly undertreating our patients. So I think people are afraid of hormone therapy in general, especially if you've had cancer. I think among patients, there's a misconception that hormones equal cancer. And so it's really hard to have this counseling conversation with them to make sure that they're reassured that for the vast majority of them, they will do better if they're given hormones. So what do I actually give? If we've come to the point where we said the vast majority of these cancers, we don't think that there's an increased risk of recurrence, well, what are we going to give them? Here are my thoughts. So some of you may have been in practice when you heard that the dogma for hormone therapy was 3 to 5 years of use, lowest dose possible, and then as soon as that 3 to 5 years goes for naturally menopausal women, it's like a hot potato and you get rid of it, and that's just not the case here. So what we're doing is we're treating until what we think is the natural age of menopause, so early 50s, but that doesn't mean they have to come off at that point. That means that you have to shift your conversation from disease prevention to symptom control. So there's nothing saying that these women can't be on it beyond menopause. The other thing is that there's a whole host of things to try. So most of us will have a couple regimens in our back pocket that we use on a regular basis, but there's a lot of options out there. And so if you're kind of, as an oncologist starting someone on something, you've got a favorite estrogen or 2 prescriptions, and then you're kind of out of ideas, please send them along to someone who specializes in menopause in your area. So some of the things that I'll tend to go to, and there's all sorts of reasons why I use certain things over the other. So conjugated equine estrogen is the one that has been around the longest. It's Premarin. 0.625 is my kind of menopausal lady starting dose, but for your younger women, you're going to end up using more. Now, what happens sometimes I find in this patient population is that they've not had hormones for a while. So they often see me after a point in time, 6 months, 12 months, like they're not necessarily coming to me right immediately post-surgical or post-treatment. So they've had this gap in time where they've been without hormones altogether and they're suffering from their symptoms. I like to start them on lower doses purposefully because I find that sometimes they'll get side effects if they just are blasted with a huge dose of like a 1.25 of Premarin or a higher dose of estrogen. They tend to get headaches and nauseous or breast tenderness. So I'll usually start them on something lower and then kind of titrate up. Your other oral estrogens, estrace is a 1 milligram starting dose, but they can use 2 milligrams and above even for some. The transdermals, again, starting doses are listed here, but I get up to 3 pumps a day of estrogel. I get up to 75 and 100 microgram patches. You just kind of have to go based on symptoms. And again, we don't know what they're supposed to be on. We don't know what the exact dose or the exact blood level is for cardiovascular prevention or bone protection. We just don't have these numbers. So we go based on symptoms and how they're doing clinically. In terms of progestogens, you'll of course be using these less because a lot of your patients don't have a uterus. But if they are left with a uterus, my go-to progestogen prescription tends to be prometrium, so our body's natural progesterone. The data behind the different progestogens is scarce, but what we tend to think is that a couple of things. One, permetrium tends to make people sleepy at nighttime. And for a lot of your menopausal patients, this is a huge win. This is what they want. They're coming in telling you that they're not sleeping. We think it's probably more neutral to the breast. So we don't know this for sure, but for instance, in the WHI, where they used continuous daily dose of Provera, medroxyprogesterone acetate, it had the highest risks to the breast as well as risks for VTE. And we think that progesterone itself is probably less risky than that. There's also a little bit of data, very scarce, but that it is out there that permetrium itself is helpful for vasomotor symptoms on its own. So if you've got a patient population who can't take estrogen, or you're worried about estrogen, although we don't know safety data on progestogens by itself, there might be some benefit to them using progesterone at night. I think there's a limited use of levonorgestrel in your patient population because most of them have either an irradiated uterus or a uterus that doesn't exist, so they don't need it. Provera is a really pretty potent compared to progesterone. It's pretty potent to the uterus, so it does a pretty good job in counteracting estrogen's effects. I tend to like it cyclically rather than continuously because I think cyclically, from what we know from even just observational studies, that it's probably safer to the breast to have a rest each month from that. But your patients do have to know that they may get a withdrawal bleed depending on their situation. I made a note that combined contraceptives are an option. We don't have any data really to tell us what is better, combined contraceptives versus menopausal. I think most of us that do menopause day in and day out tend to like menopausal therapy better. It seems really intuitive to just give these patients the pill, but I find that symptomatically they're often a lot better with menopausal doses versus contraceptives. And we, just from a tiny little bit of data with like very tiny studies, they might be better served in terms of their bones from the use of menopausal therapy. So it's more physiologic. The counter to that is that contraceptives are, of course, they're really easy, right? Like, and their peers will probably be on it, or they'll know they might have been on it themselves. So it is an option. I don't think it's a bad option. Just know that there might be differences that we'll come to learn. Okay, I'm going to skip over the vaginal stuff except for just showing you the options for therapeutic management. So in Canada, we have 4 prescriptions available for genitourinary syndrome of menopause, and they're not all created equal. So you each probably have your own favorite that you go to, but if one isn't working, then please try something different. So the creams tend to have higher circulating levels, although they all stay within really low menopausal ranges. The ring is good if patients are willing to use it, and the tablet for some people works really well. So this is what it looks like here. Just a brief minute on alternative prescriptions. So if we're unconvinced or we're unconvinced about hormone therapy and its safety, there are other things for these patients that we can go to. So SSRIs probably have the best data behind them. They get symptom relief fairly quickly, and we tend to use doses that are lower than what they would use if they were using it for depression. So I think this is one of the barriers that we come to is patients say, well, I'm not depressed, I'm not interested in this. And it's working differently. We don't fully understand how it works, but because the doses tend to be lower and the onset of effect tends to be quicker, there's something different about how this works for vasomotor symptoms versus mood symptoms. Of course, you get the mood benefit as well if you have patients that have mood concerns. Gabapentin is something that I go to fairly frequently for especially for nighttime symptoms, because gabapentin itself has a lot of side effects, especially if you go too quickly in terms of your use starting it and you go too high on your titration. But if you start low and go really slow, a lot of patients tolerate a nighttime bedtime dose, so they sleep better and vasomotor symptoms are improved. Clonidine, I will admit, is my least favorite of the non-hormonal prescriptions, but for some people it works. So please, by all means, try it. The other thing that I wanted to mention really, really quickly, and I've sort of alluded to this already, is although we're talking about relieving symptoms of hormone therapy, I think there's pieces that we're just not we're just not quite getting to. And the one that comes up continuously is sexual side effects. So especially with a gynecologic cancer, this is, of course, going to be a multifactorial problem. It's not just something that we can blame on hormones, and we shouldn't blame on hormones, but it's something that as our survivorship grows, we need to really start paying attention to this a lot more. Perhaps not your role, but other healthcare providers should be paying attention to this as well. So very, very quickly, testosterone therapy not indicated for women in Canada, nor really for anywhere. But there is data, especially in the BSO population, albeit a benign patient population, that it can work there. So why do these patients need hormones? Just in conclusion, the symptoms are pretty terrible. And more than likely, they're going to live longer, healthier lives if they're given hormone replacement. It's the gold standard for management. There is observational data that supports the use in most or many gynecologic cancer survivors. That's all I had. Yeah. Thank you.
I think maybe in the interest of time, we can take one question or two questions at the most. Okay.
All you ever needed to know about menopause.
I'll ask your question. Sure.
Thanks, Sarah.
Just because I know we've talked about it a whole lot, can you just maybe say a word about the data or lack thereof for the triple negative breast cancer patients? Because we come across this all the time in our BRCA population.
Yes, no problem. There was an obvious omission that I didn't talk about breast cancer patients here. Breast cancer and hormones is, again, a data-free zone. So I think that there's this conception that if someone has a personal history of breast cancer and it was ERPR positive, then they can't get systemic hormone therapy, but the patients that have ERPR negative tumors can. And I think we've all got this image in our minds where hormones, you're pouring a watering can of hormones onto a tumor and it's growing the estrogen receptor ERPR positive tumors, and it would be unaffected if you were negative. There's data to support indirect and direct influences of hormones on the growth of estrogen or on breast cancer. It doesn't matter if they're hormone positive or not. So I think it's less simple than we like to imagine. The take-home message at this point is if you're ERPR negative, really technically you're not supposed to have systemic estrogen. I say that, and then I know that we're probably especially in years to come, we're probably going to be doing these current patients a disservice because we don't fully understand breast cancer. It's just such a huge topic. If you look at, for instance, the Women's Health Initiative, huge randomized controlled trial showed an increased risk of breast cancer in the ERPR positive or in the estrogen progestin arm. They were not all ERPR positive tumors. So we've got a big RCT data set that shows us that you have increased risk of breast cancer of both types in the setting of taking hormone therapy. So there's something more to it than that. I have a really long counseling conversation with these patients because, of course, some of them are left to cycle on their own, right? Like they may not be, I've had patients that are not rendered menopausal, so they've got their own circulating estrogens, and then the question is, well, what do you do in menopause, right? Or like a natural menopause. Like it's so complex. It's like a really long conversation. We just don't know. The textbook answer is that it's no, but there's definitely a few that you counsel about risks and benefits, and they end up going on.
Okay, one last question.
Thank you. Very, very interesting. We have recently sent many patients for acupuncture sessions with great results.
Oh,
so I just wanted to share with the rest
Yeah.
of the colleagues that it could be something to think about and offer to patients.
Yep. Yeah, there's pretty much everything under the sun has been tried to fix menopausal symptoms. There's a few interesting points to that. So placebo effect in menopausal management is huge, probably in the realm of 25 to 50% for most things. If you look at big reviews of acupuncture, they just aren't done properly. So they don't have sham acupuncture that's proving that sham acupuncture would be as good or not as good as other like true acupuncture for vasomotor symptoms would be. all sorts of other data in terms of, are other non-prescription hormones helpful, like are soy products helpful? Is weight loss helpful? Is yoga helpful? Black cohosh, like everything has been tried, right? And there's data to support some and not others. I think the important piece to remember is that if they have no increased risk of being on hormones, like if they're a cervical cancer patient where you think that like this is not someone I'm worried about, that you don't give the impression that hormones are unsafe and you should try all these other things first. Because I think if you're delaying their misery and they're continuing to try all these things and they're just like, well, why isn't it working for me? Why why isn't this helpful? Then it's important to give the right message. Of course, if they're at increased risk with the use of hormones, then they should absolutely try all the other things that they can.